Coming up next on Functional Moms Podcast.
As women go through perimenopause and have chaotic hormone levels, or then menopause where estrogen declines, we see an increase in inflammation, so increase in joint pain, increase in things like frozen shoulder. We see a spike in women over the age of 50 in terms of, women being more likely than men to develop arthritis. And then in terms of bone health, we know that in general, women and men are over the age of 30 when we peak in our bone density. We typically are losing maybe 1% of our bone density per year. But for women, this accelerates at menopause to 2% of your bone density per year. So in the absence of hormone therapy, women are now more likely to have arthritis, but they're also more likely to have accelerated loss of bone density. That's why women are the main group affected by osteoporosis and then fractures that are related to low bone density.
Welcome to Functional Moms Podcast, lifestyle medicine for women over 40. Let's age on our own terms.
This episode is for you if you're a woman over 40 looking to prevent and treat osteoporosis and arthritis. We are going to learn how perimenopause and menopause impact our bones and joints.
Dr. Jocelyn Wittstein is an orthopedic surgeon specialized in sports medicine and associate professor of orthopedic surgery at Duke University School of Medicine.
Dr. Wittstein is co-investigator with Dr. Ann Ford of Duke Women's Health for the Duke Musculoskeletal System of Menopause Registry. She is president of the forum Women in Sports Medicine, co-author of the Complete Bone and Joint Health Plan, and a mom of 5. Her husband is also an orthopedic surgeon.
Dr. Wittstein, thank you so much for coming on our show today. We would like to begin by asking you how perimenopause and menopause impact bone and joint health.
Thanks for having me. And that is a monster question. I'll try to break it into bite-sized pieces for you.
Absolutely.
Also, thank you for that introduction. So, big question. Yeah, how does perimenopause and menopause affect our bones and joints? I think to start to answer that question, you have to think about all the things that estrogen does. Certainly contributes to reducing inflammation in our body and our joints. Estrogen in our bones has a specific effect on inhibiting osteoclasts, kind of making them not live as long. So the osteoclasts are the cells that kind of break down bone. So sort of net positive of bone building or maintaining bone density when estrogen is present. So in general, as women go through perimenopause and have sort of chaotic hormone levels, or then menopause where estrogen declines, we see an increase in inflammation. So increase in joint pain, increase in things like frozen shoulder. We see a spike in women over the age of 50 in terms of, women being more likely than men to develop arthritis. And then in terms of bone health, we know that in general, women and men are, over the age of 30 when we peak in our bone density. We typically are losing maybe 1% of our bone density per year. But for women, this accelerates at menopause to 2% of your bone density per year. So in the absence of hormone therapy, women are now more likely to have arthritis, but they're also more likely to have accelerated loss of bone density. That's why women are the main group affected by osteoporosis and then fractures that are related to low bone density. So that's kind of a broad sweeping overview.
Yeah, that was great.
The impact of menopause on your bone and joints in the most general sense.
And so what I'm hearing is it's mostly the estrogen. Would the other hormones impacted too, like the loss of progesterone?
Well, most of the data and studies on the effect on joint health are estrogen related. Interestingly, there was a recent study on testosterone levels, that low testosterone levels in both men and women is associated with greater likelihood of arthritis. But in general, most of our understanding about the increased joint inflammation and the impact of hormones on bone density in women is related to estrogen withdrawal.
Okay. And so what do women do then about that? Because if you are not a candidate, say, for hormone replacement therapy, are there other options?
Yeah. So certainly we don't want everyone to feel like they have to use hormone replacement therapy, although menopausal hormone therapy is a good option for maintaining bone density and reducing inflammation. And just in general, some of the studies looking at the effect on bone density with menopausal hormone therapy show, improvements in bone density on the order of 4 and 5% and reduction of fracture risk that is significant. But let's say for whatever personal reason or through your discussion with your women's health provider, maybe you're not a candidate or you just decide you don't want to use hormone therapy. There are other things women can do to maintain their bone density. And the number one thing is strength training or resistance training. And one of the best done studies on this was called the Liftmore trial, which was a randomized study where they had women who were menopausal with low bone density gradually participate in just some like lesser sort of independent exercises versus a more intense exercising program where they did gradually progress women to what's called high intensity resistance training, where they were doing like squatting, deadlift, overhead press with repetitions at 80% of their maximum one time rep. And then they were also doing some jumping pull ups. So, including a little bit of a jump, a little bit of impact, and then some higher intensity strength training. And what was found in that trial was that women gained 3% in their lumbar spine bone mineral density, as opposed to the control group, which was losing about 1%. So, certainly, resistance training is one of the things that women can and should do a few days a week, really hopefully beginning earlier in life, but certainly incorporating that as we reach this phase where our bone density declines more rapidly.
Right.
Incorporating a little bit of jumping or impact can help. There's a great study that showed incorporating, about 30 jumps a few days a week. It could be jumping rope, could be jumping jacks, could be jumping holding onto the back of a chair. Incorporating some impact in that way helped with increasing the bone density in the hip by about 1%. So we know impact stimulates bone density.
Can I pause there for one moment?
Yeah.
When you talk about jumping, right? Because, like, I know so many women that have knee issues are
Mm,
like, "How am I supposed to jump? I can't
right.
jump. I'm gonna crush my knees. Like, I'm gonna be in so much pain." So, can they do things like maybe like doing like battle ropes, or like if you're sitting down and doing this, like, would that be like I'm sitting down on a chair and I'm just like
Right.
jump like doing like a jump off my butt on the chair.
So if you look at the studies of like more of the strength training versus impact exercise, the strength training actually seems to benefit more like your increase the bone density more in the spine and the impact training a little bit more in the hip region. So if you can't tolerate jumping, like let's say you have some knee arthritis, and this is so common because of course
Right.
people who get bone density problems are also getting arthritis. There's some evidence that you can benefit from doing like pool-based jumping. So if you have access to a pool where like part of your body is out of the water, part of it is in the water, you still have to overcome some of the resistance to jump out of the water, but then your landing is a little bit cushioned, but still some impact on landing. That is one way that you
Okay.
could still do some jumping. It's probably not as bone loading and stimulating of bone density as the land-based jumping, but that still helps some. And so you're right, like jumping isn't for everyone, but you could also still like try to incorporate walking. That is load bearing. You're not getting as much impact as jumping, but
Right.
walking is good.
But it's still a weight bearing.
Yeah. You could walk with a weighted vest if it doesn't hurt your knees. It kind of depends on like what. So sometimes people have knee arthritis, not all over their knee, but just behind their kneecap. And those people may do fine with walking, even with a weighted vest on for some increased load to stimulate bone density. But what their knee is not going to like is walking downhill, because
Mm.
walking downhill is going to load their kneecap more. So like, the answer is a little bit different for every woman or every person. And the key is like finding ways you can work around what limitations you have to do the things that help you build muscle and stimulate bone density.
Right, I get it. So basically, it's like depending on the type of plyometric you're doing, some like if you're doing jumps, that will work specifically for like hip, like your hip. And then because like doing ball slams or battle ropes, is that considered like that type of impact because it's bringing that like you're slamming?
That would probably help with more of your bone density in your upper extremities. And this is an
Right.
interesting question, actually. Bone density can be like local or focal. So it isn't, we do like you to incorporate, because, one of the areas that people will often sustain a fracture is like their wrist or their shoulder, what we call the proximal humerus. Those are areas that people with low bone density can break their bone. And so it's good to try to incorporate upper and lower extremity strength training.
Right, right. Okay, so that's great.
What about we get a question a lot about jumping on a rebounder. Would that help at all with bone development or maintenance?
I mean, on like a little
Yes, yeah.
trampoline. Yeah, that does help some with bone density. That's another way to like cushion your knees some.
Okay. And because some information we've seen, they're saying you should really be jumping more like pogo style. I guess that gives you more like a force going through the body. But I found when I tried that it's kind of hard, that it doesn't feel that great because you feel kind of that jolt.
Well, and here's the thing, you don't have to do a ton of jumping. I mean, I tell people, like, if you can only do, like, 30 jumps a few days a week, like, that's good, that helps.
That makes me feel better.
It's that you don't have to jump for 30 minutes. It actually doesn't have to be like that many jumps. And I think that helps people participate in that.
So you're saying 30 jumps a couple of times a week.
Few days a week.
All right. So it's not 30 jumps in total of the week, but it would be like 30 jumps on Monday, 30 jumps on Wednesday, and 30 jumps on Friday, for example.
Yeah, and you could separate it like 10 at a time. Like when I go to the gym and I do like hanging or pull-ups, I like to do that. I have the little step I use to get up onto the pull-up bar. In between, I just jump down from it 10 times. Then in between the sets, I've done 30. So it doesn't
Yeah.
have to be a ton of jumping.
Excellent.
That's great. That simplifies it.
Yeah, keep it simple. Yeah.
I know you touched upon this at the beginning, but we'd like to ask you, what is menopause arthritis?
Okay, so the best way for me to explain this to people is think about the two extremes of arthritis. You have osteoarthritis, just wear and tear, mileage on your tires, right? Like you're wearing down the cartilage, which is that smooth gliding surface of the joint over time as we age. That's mostly, it can be like mechanical, just use, like literally aging of your joints. Maybe you're aligned badly. Maybe you're super bow legged or really knock kneed. And so you wear down parts of your joints faster than others. That's still mechanical. There are some inflammatory aspects to osteoarthritis, actually. It's just a lesser component of it. The far end of the spectrum is the sort of autoimmune inflammatory conditions like rheumatoid arthritis, psoriatic arthritis, lupus, things like that, where people are getting joint inflammation, where their joint surface is being, attacked and broken down by these inflammatory enzymes that can be blocked by medications that are called DMARDs, medications that counteract rheumatoid arthritis. That's the other end of the spectrum. Then you have types of arthritis that are like somewhere in the middle. Like, yes, women going through menopause are aging, their joints are aging. There's probably some wear and tear happening, but it's accelerated by this, increased inflammation that we see with the withdrawal of estrogen. The lining of our joints, which is called synovium, has estrogen receptors. And there are a lot of basic science studies, including animal studies, showing that, withdrawal of the effect of estrogen increases the inflammation in the joints and increases the breakdown of cartilage. Treating joints or treating with estrogen ameliorates that effect. In the shoulder, there was a recent animal study, mice study, that showed that estrogen inhibited some of the inflammatory cells in the shoulder and the cells that are called fibroblasts that make the joint stiff and fibrotic. So there's definitely a combined hormonal effect and probably aging effect as well. But there's a reason that women are 30% more likely than men to develop arthritis and are more likely to need knee replacements, and that men don't really, catch up to where women are until they're like 80. So
Wow.
it's a combined effect of, yes, aging, but also hormonal influences on inflammation and direct hormonal activation or lack of activation of those estrogen receptors in the linings of the joints.
Okay, so I'm hearing it again, we're going back to estrogen, like going declining, and then we're getting inflammation that's making us more prone than men. And so then we would also like to ask you about the frozen shoulder, because we hear that this is so common in perimenopause
Mhm.
and menopause. And we'd like to know, I guess, is it the estrogen that's causing that, or what else is involved?
Yeah, so I do a lot of work on frozen shoulder in combination with our Duke Women's Health team. And that's part of the impetus for us, honestly, establishing this registry that we have looking at musculoskeletal symptoms in menopause. But yeah, frozen shoulder is funny because it really affects women between the age of 40 and 60. It rarely affects men, unless men have poorly controlled diabetes. That's a typical group of male patients to get a frozen shoulder. But, it's for years and years, it's called idiopathic, which just means we don't know what causes it, right? And I always kind of joke, and I think truly it's been labeled as idiopathic because it mostly affects women, and like only 6% of orthopedic surgeons are women, and that's a more recent phenomenon. So I think it would have been labeled as idiopathic for a lesser period of time, perhaps, if things were flipped. As much as
Right.
I love and adore my male partners, I just think that they're not going to get frozen shoulder. But, so it's really hard to think that something could be idiopathic when it mostly affects women age 40 to 60, which corresponds to that time of perimenopause and menopause. And it's so prevalent in some cultures that, like, Japanese and some Asian cultures, they have their own terminology for frozen shoulder. They just call it 50-year shoulder, and their mom got it. They're just expecting to get it. And it's really
Wow.
this self-limited condition where the shoulder becomes inflamed and stiff. And then, so at first it's very painful, and then with no trauma, and then it stiffens and freezes, and then it thaws. And we were just speaking about that recent animal study showing the actual kind of mechanism may be that these cells in the lining of the joint that are called fibroblasts kind of thicken and make the lining of the joint like less flexible. But so I've done some research on this. It's really hard to get adequate power to study this because if you look at women not using hormone therapy and women using hormone therapy, only like 5% of women use hormone therapy. So you need just massive numbers to get enough women in the hormone therapy group that would actually get a frozen shoulder to make clear conclusions. But in our preliminary work, we just had so few people in the hormone therapy group getting it. And they were a smaller group that we were seeing like half the risk, but, approaching but not yet attaining statistical significance. So that's why we started the registry. But I really think based on, basic science of what we know estrogen does, that we know the lining of the joint has estrogen receptors, some of the basic science we see from like animal studies makes so much sense to me that this withdrawal of estrogen makes the shoulder become inflamed and stiffer. And it's
Right.
really common for people to get on one side and then the other. I personally developed this condition several months ago, and I'm a perimenopausal woman. I just happen to be a female orthopedic surgeon, so I knew what it was right away and started treating it. But it's the most common reason for shoulder pain in this age group for sure.
I would love to ask, like, how do you treat this frozen shoulder? Like, for this specific woman, like all of like you, how did you treat yourself?
Yeah. So the thing about frozen shoulder is if it's a self-limiting condition, if you do nothing, it'll go through the phases, but it can take a long time, like can take 1 to 2 years to kind of resolve. So who wants to go through that? And
Right.
it's really painful when you have it. And it can be very impactful on your daily living, especially if you get stiff. There are a lot of things you can't do, like wash or shave under your opposite armpit, like fasten a bra, get your
Right.
coat on. I mean, for me, that would have been doing surgery on people. And my go-to for patients who hopefully present within a few months of onset of symptoms is to put a steroid injection, a cortisone injection, as you may call it,
Right.
into the ball and socket joint in the shoulder. Because if you catch this early enough, it actually cures the problem, reverses it, keeps them from that year-long process. It's the
Right.
best indication for a steroid injection because it's not a band-aid, it's often a cure for the problem.
Mm.
This being said, my own personal decision, and seeing how many people go through frozen shoulder on one side and the other, I went ahead and in perimenopause started a transdermal estrogen pad because I was having some other things like my LDL was creeping up, a random night sweat here and there, stuff like that. I did not want to get frozen shoulder on the other side. And at this point, I really think of frozen shoulder as being a symptom of perimenopause and menopause. I'm not telling people, oh, you have a frozen shoulder, go get an estrogen patch. But for me, it was coinciding with some symptoms of perimenopause. And I do work really closely with our women's health doctors. And so often my patients who are having the symptoms of frozen shoulder are having other symptoms. And it just makes sense for us to work together in treating that patient.
Right. I noticed that you said that if you catch it early on, you
Mm.
can do that. What happens if you didn't know that and you didn't catch it early on? Are you like just like, are you still able to do that?
Yeah. So if someone comes to see me and they're more than a few months into the frozen shoulder process and they're kind of getting stiffer already, they're losing the range of motion, kind of getting into what we call that frozen state out of the inflammatory state, you can still do an injection and it will often still help. It doesn't kind of right away restore all the range of motion. They still have
Right.
to thaw and get their range of motion back, but physical therapy can be helpful at that point
Okay.
to work on the range of motion. The injections just aren't as magical and
Right.
I mean, if I have a patient with adhesive capsulitis, which is the early phase of frozen shoulder, and I catch them within the first few months and I give them an injection in their joint, most of them come back and say, I want to hug you. This was magical. I feel so good because it works so well early. It just doesn't work as well, farther into the process.
Right. So, well, many women begin to experience also elbow, knee, hip pains in their 40s and 50s. And is this cause similar to the frozen shoulder? Like, I can say for myself right now, and this has been going on, this started last summer and I didn't fall, I didn't have any issue, but my elbow, I started getting I'm like, gosh, my elbow is feeling really stiff and tight.
Mm.
Now, I was doing I was simulating like I'm doing rope climbing. So I knew I was doing that.
Oh, the thing where you pull the rope pull thing at the gym?
Well, no, it's like it's a rope that comes it was at my son's wrestling club, and so it's like you can go all the way up. So what I do is I wasn't going all the way up. I was like training myself to go all the way up. And
Mm,
I would just put the rope like between my legs and I would go up and I would bring myself down and I was just really carrying the bulk of the weight of my body. Like I was just training myself for it and I was doing pretty good and I did go up. But
mhm,
so I don't know if like if that might have had something to do like that might have started something. But that was like and then I stopped doing it. I was like, all right, I was feeling a little and it never went away and it's still going on. So then I went to physical therapy for a minute and she was like, I think this might be connected to your shoulder. I feel like you have tight shoulder and it's somehow going into your elbow. And I was like, okay. But then I started hearing more and more about this frozen shoulder and like just this whole thing. And now I am like at least 5 years postmenopausal. So I'm like, well, maybe I'm like there. I have no idea, but I didn't know. Like, is there such a thing as frozen elbow?
well, you people can also just get, tennis elbow or lateral epicondylitis from repetitive gripping. But yeah, I mean, I think in general, what tends to happen to a lot of menopausal women is they start to have this like acute increase in like multiple things hurting. And they're like, what is this? Like, why is this happening to me? And then they go to a bunch of orthopedic visits or doctor's visits. And a lot of times x rays are normal. And, you're kind of just like told, oh, you're just getting older. And, it's
Right.
so the tricky thing, it's hard to say is like how much of it is overuse or a little bit of aging or wear and tear versus like this increase in inflammation and just having more harder time like recovering from things.
Right. Right.
If you look at, the early studies from the Women's Health Initiative where they just looked at like joint pain very vaguely, like what percentage of women in some of these studies had joint pain, like 77% of people were reporting joint pain. And then people were, randomized to hormone therapy or not. And hormone therapy did reduce the number of and severity of painful joints. And then stopping the therapy did, associate with some like rebound in that pain. So it's just the relationship between hormone therapy and joint pain is not as tightly and clearly understood as is like bone health. So, like hormone therapy is an FDA prevention of osteoporosis is an FDA approved utilization of menopausal hormone therapy, as are things like vasomotor, symptoms of menopause, for instance. But like preventing arthritis or joint pain isn't necessarily like an approved indication. It's just the connection isn't quite as clear, even though there's a ton of basic science evidence to suggest, and even clinical evidence to suggest there's, a relationship. But so often times when people are having this increased number of joints and, irritations and things like that, it's coinciding with these other aspects, right?
Right. Yeah.
Yeah, and we hear a lot from people that have come on the show even that they've started hormone therapy or menopausal therapy and their pain goes away. They will say quickly they notice a difference.
Yeah, I think inflammation is a large component for a lot of people. Mhm.
Which makes sense.
Now, I probably have, like, a biased I'm an orthopedic surgeon, so I see people all day with joint pain and, tendon pain and broken bones and things like that, so I have that lens, which is but I also hear them tell I can also see because I work in a system where, people are seeing doctors within a network, and I can see, like, this woman has seen this doctor for sleep problems, this doctor for anxiety and depression, coming to see me for her painful shoulder. There's a message to her primary care about why are her lipids getting worse, and so there's, like, a lot of things all happening at the same time, and someone has, maybe put her on a sleep medicine and an antidepressant, and then they've maybe given her some Ultram for shoulder pain, and all of a sudden this person is on, like, a lot of medications that where maybe there's a commonality, maybe a lot of it is related to
Right.
their hormonal.
Yeah. Well, thank you for connecting the dots for us women because
Yeah. That's serious.
Yeah, and so sometimes I do provide a lot of referrals to women's health, and I know you were talking about you were on my Instagram the other day, but, like, I was in clinic with one of my fellows who I love dearly, who's as thoughtful as you could be as a male orthopedic sports medicine fellow. He's married to a women's health doctor, and he literally said to me, "Are you some kind of, like, kingpin for some sort of hormone therapy ring? Like, what" you're like, "I've never seen so many referrals to women's health from an orthopedic clinic," but so many times, like, the musculoskeletal symptoms are so prominent and they're women are like, who can I see who will help me with this? And they're just like having trouble finding, the right clinic or provider. And I don't prescribe hormone therapy. That would be out of my realm, to be prescribing that because that's really a detailed conversation, risk benefit assessment, and, something that needs to happen with women's health or your regular doctor. But I do like to direct people that way if they're, presenting with all of that.
Right.
absolutely, and that is so helpful. helpful. And that brings us to asking you about DEXA scans, what they are. And we've heard you're not supposed to get it till 65, but that seems like waiting too long to us. But we'd like to know what your thoughts on are.
Yeah. So DEXA scan is an imaging study that gives you a report of your bone mineral density. And that is how we diagnose whether or not you have like low or normal, bone mineral density. So if you have some thinning of your bones or some, mild loss of bone density, we say you have osteopenia. So you get a score, you get a T score. So if it's between -1 and -2.5, that's osteopenia. The more severe version would be osteoporosis. So if it's lower than -2.5. And then, that's your score, and that is one piece of the puzzle in terms of assessing your risk for future fractures. And, certainly bone mineral density is something that you can modify through some dietary and exercise and lifestyle choices. But it is a major factor that contributes to your risk of fracture over time. And if unaddressed and you don't do anything about it, like, yeah, your bone mineral density is going to decline, on average 1% per year. And then when women hit menopause, 2% per year. So it is a good thing to be aware of and be proactive about. The current recommendations for women to get this at age 65, and I also think that is too late. The main reason I think it's too late is that, if you were to get that test when you were 50, 51, 52, when you're like deciding about whether or not you want to use MHT, menopausal hormone therapy. So if you're trying to make that decision and you want to have an informed conversation, it'll be useful to know if you already have a little bone loss or where you stand when you're starting. Because if you don't get that data until you're 65, you shouldn't start hormone therapy at 65. So you've kind of maybe missed a potential intervention. And the other thing is our bone mineral density starts to decline at age 30 a little bit year after year. So depending on the risk factors you had leading up to that, like were you an athlete in your teen 20s where you exercised so intensely that you had an energy deficiency syndrome and had periods of time where you had no menstrual cycles? Like that person could arrive at 50 with osteoporosis.
Wow.
There are all kinds of scenarios where it would be helpful to know sooner rather than later what your bone mineral density is.
Yeah.
Sure. And so I guess for right now, you could possibly get one, but you would just have to pay out of pocket. Like you're not going to get it covered.
It depends on the person's insurance. I've had women be able to get them covered by insurance, at 50, and especially if you can sort of indicate other risk factors, maybe. But otherwise, yeah, a lot of policies don't cover them that early, and then people end up, getting them later.
Yeah.
Hmm.
You recommend limiting red meat.
Mhm.
How can eating red meat contribute to bone and joint problems? I love red meat.
Well, I think, yeah, in general, for like in terms of an anti inflammatory diet, limiting red meat or choosing lean cuts, like in general, you want to eat lean proteins that are not processed. I mean, I guess that may be an easier way to look at it.
Okay.
Yeah, I think I don't ever wanna tell someone, "Don't ever do something." I think that's really
Sure.
don't ever eat ice cream. Like, I eat ice cream sometimes, not a lot, but or don't ever drink wine. Like, I have a glass of wine occasionally. So, I think, yeah, I would suggest in general, though, trying to as part of an anti-inflammatory diet, yeah, choosing lean meats, not fried, lean proteins, not processed. That's one component. I mean, you have to look at the whole picture. Certainly, there are pro-inflammatory and anti-inflammatory components to diets. There are so many anti-inflammatory components you can build in, like a lot of getting adequate fiber, a lot of variety of different fruits and vegetables in the book that I wrote with my co-author, Sydney Nitskorsky, who's a registered dietitian. We kind of go through a lot of all the details of all the different
Oh, that
phytochemicals and anti-inflammatory aspects of various fruits and vegetables, because I think sometimes if people know more about what they're eating, they're more likely to eat it because they know why
yeah.
it's good for them. But other aspects, including omega-3 fatty acids in your diet, including there are a lot of anti-inflammatory spices people can use. And these aren't like magical things. Everything you can do that's part of your dietary choices adds up to being like, anti-inflammatory or pro-inflammatory. And then just like your exercise choices, it all adds
Right.
up. So it's not like there's like one magic thing, like I'm going to put
Right.
turmeric on my eggs. Like it's not like that alone is going to cure you. It's just these things all add.
Right. Let me down that turmeric.
Yeah, although I do love turmeric and I do love a lot of the anti-inflammatory spices. Yeah, turmeric is really good for you. But yeah, I don't want people to think that there's like one magical thing alone that, cures these things.
Yeah. So basically, what you're saying is like, so red meat, like fatty cuts or like cold cuts, that can really contribute to bone and joint problems. But try to, like, if you eat red meat, like, try to have leaner cuts and then have on your plate, like, some fibrous foods, some of the other to make your whole plate so that it's a nice balance.
Yeah, like include healthy fats. Like olive oil is a great choice almost always. It has a lot of there are anti-inflammatory aspects to olive
Right.
oil. So I mean that's like kind of my go-to like fat source
Yeah.
always. And then, fish is really anti-inflammatory and has high omega-3 fatty acids. Like salmon is a great choice to add, but not everyone likes fish. I will admit one of my worst health habits is like I don't like fish or eat fish. And so like I take some fish oil because I don't eat salmon.
Right.
Right.
None of us are perfect.
Yeah. No, a lot of people don't like fish, that's true, so that's helpful.
Yeah, I wish I wanted to eat salmon.
Yeah, well, and you just said you take it, like, in the pill form, so what supplements can help with bone and joint health?
Yeah, and I don't want people to think you have to take like a shelf of supplements, but in general, I would say try to eat your calcium. It's hard to necessarily get as much vitamin D as might help us through our diet. Like vitamin D is in actually, salmon, fatty fish, eggs, actually in mushrooms, but there's a lot of good data about vitamin D above the recommended daily value being helpful for various things. Like there are some studies about even like dementia prevention, reducing joint pain if you are taking a dose of 2,000 international units daily, certainly helping with bone density. So that is one supplement I take. I take 2,000 international units a day daily of vitamin D. You're not going to get anywhere near being too high. It's not a huge supplement, but there's some data behind that.
Would we have to take that with vitamin K too?
So if you have a poor diet, like you don't eat like a lot of like leafy greens and a variety of vegetables, like if you think your diet is not including any vitamin K, I would take it
Mhm.
with vitamin K. Like you'll often see it
Okay.
packaged with vitamin.
Yes, yeah, that's why I asked, okay.
I don't want to get too off track, but when you intake calcium, your body needs vitamin D to help you absorb it. Your body needs magnesium to help activate your vitamin D, and then your vitamin K kind of helps direct it to your bones. So,
Okay.
there are multiple nutrients that we need for getting adequate nutrients for our bones. But so back to the supplements, I do take magnesium glycinate, 400 milligrams a day. You can get magnesium in your diet as well, but that does help a lot of people with sleep. It is like a cofactor for activation of vitamin D to help you with calcium absorption. Curcumin supplements can help if you have joint pain and you're someone that's otherwise dependent on non-steroidal anti-inflammatories to like get through the day. Like if you're like, I have to take ibuprofen every day or gonna leave breakfast and dinner, like that's really not a great thing to go on doing forever and ever. So curcumin that's part of turmeric, the spice. So you can
Yes.
get some curcumin from actually just eating turmeric, but you can also get supplements you'll see ranging from 12 to 1,500 milligrams in pharmacies. This is pretty data driven. There are studies that show that helps people not need NSAIDs. You'll often see it in combination with piperine, which is black pepper, because that helps increase the absorption of curcumin. So I don't take that regularly. Right now, I'm not having like a lot of joint pain, but I will use that sometimes instead of an NSAID if I'm having a flare up of something. Interestingly, I was mentioning after I got my shoulder issue and initiating transdermal estrogen in my perimenopausal self state, I am having a lot less joint inflammation. So I'm really not needing any curcumin, but that's a great supplement. And then, fish oil for omega 3s. If you're someone that doesn't eat fish a few days a week, I think that's certainly a great thing. One supplement that I think is super well studied and gets back to many things that women are afflicted by is creatine monohydrate, 5 grams a day. That does help with maintaining muscle mass, increasing strength, helping with strength training programs. And then indirectly, that can help with bone density. It doesn't directly improve your bone density, but it helps with, strength training regimens. And there's some evidence of cognitive benefits. So, women are more prone to dementia than men. And so, my mom had dementia. So I kind of just been looking at literature on potential cognitive benefits and strength benefits and then indirect bone health benefits. And I take 5 grams of creatine.
I have to ask you about this because I was
Right.
incorporating this. I've seen all these great, studies, information about how great creatine is, and I was getting heart palpitations from it because when I stopped, it went away.
Oh, interesting. Well, a lot of women in perimenopause get heart palpitations, and I don't want this to be all about me. I had a bunch of
Yeah.
heart palpitations, and that's actually a super common symptom. And a lot of women go and they see their cardiologist. And I mean, I wore the monitor for weeks,
Mhm.
didn't really
Yeah.
show any concerning. And actually, one of the first reasons I started taking the magnesium glycinate is my cardiologist recommended it because they're like, like so many people get this, and just going on the magnesium will help resolve that, and it really does. So
Good to know. Okay.
talk to your doctor. Maybe 400 milligrams a day of magnesium glycinate might help you, but or like, yeah, I mean, go get a monitor and get it checked out. But that's sort of like non-specific random palpitations is commonly seen in women in perimenopause as well. But yeah, I don't know. I think again, anything you try can have a different effect on various people, but it is a very well
Right.
studied supplement and is pretty safe. Last supplement I want to touch on is collagen supplements. And there are different types of collagen supplements. So the first
Yes.
kind of breakdown of this is like hydrolyzed and undenatured. So hydrolyzed is like the collagen peptides. So peptides are just, short chains, right? They're just broken down. That's the powder you're going to scoop and put in something like in a smoothie or coffee or whatever. And so sometimes you'll see it says it's for like bone, joint, skin, hair, nails. Like all of that is those descriptions are coming from like what type of collagen is in your hydrolyzed collagen supplement. So if you are looking to use hydrolyzed collagen for bone density, this supplement would need to include some type 1 hydrolyzed collagen. That's the main type collagen in bone. And there was a type that was studied by this brand called Fortibone that they produced some pretty good data showing benefits where there was some improvement in bone density in menopausal women with low bone density who are using this supplement regularly. So, I've used collagen supplements that include Fortibone. And then the other types of collagen you'll often see if there's benefits like bone and joints, you'll see typically included type 2 collagen, which is like that's the type of collagen that's primarily in what lines our joints. And there is some benefit that this can help joint symptoms and reduce joint pain. Does it actually slow progression of arthritis? We don't know. And then there's another type of collagen that's called undenatured collagen. So that would mean like you're not really going to digest it like you would these peptides. But there's evidence for something called UC2, undenatured type 2 collagen that you can get in like a 40 milligram capsule. Some basic science studies that show that people who utilize that supplement have blood tests like less breakdown products of cartilage. And the presumed mechanism is through something called oral tolerance, where your GI tract is like exposed to the type 2 collagen and then perhaps maybe your body breaks down less of it. But there's some pretty reasonable evidence there. So for people who are like, I just can't deal with scooping this, whole thing of hydrolyzed collagen into something and drinking, and I just can't do that, you could consider trying 40 milligrams of undenatured type 2 collagen. You'll see it marketed as UC2 collagen. That would be for your joints, not for your bones.
And so that would just be in a pill that you could take,
Mhm.
a capsule.
Mhm.
Okay.
Yeah.
And what about, I've heard like that if you use the powdered form that in hot coffee that it could change like the effectiveness.
Yeah, denature it, like, if you
Yeah.
were, like, boiling it or something. Yeah, I put it in smoothies, not coffee, because I don't know the answer to that, but it just seems like, yeah, putting it in really hot.
And it kinda clumps up. I have tried that, and it kinda clumps. Yeah.
Yeah, it doesn't go well in hot things.
Right, well, I did do it, but I used that little thing that froths, like so it would, like, kinda mix it in there because it didn't have a flavor,
Yeah, blending, yeah.
but then I heard that it could change the composition because of the hot whatever, and I'm like,
Yeah, I think that's a little unclear, yeah.
"Okay."
You could put it in a smoothie of some sort, that would be a reasonable option, so I put everything in smoothies, collagen powder, ground flax, hemp seed.
Right.
You can put a lot with frozen banana and frozen fruit.
Yes,
Whey
yes.
protein, yeah, smoothies are magical, yeah.
Absolutely. It makes it easy. So we have to ask you, how do the GLP-1 agonists affect bone and joint health? Because so many women over 40 are using them now, and we're curious what your thoughts are on that.
Yeah, this is a really emerging and interesting topic, and I'm actually starting a new study on this in relation to some orthopedic conditions, but there seems to be a pathway for bone health. So first of all, if you look at studies in terms of risk of fracture, like breaking a bone, if you're someone who even if we're looking at people of similar body weights and we're wondering like do these medications like make you more likely or not to have a fracture? Some of these studies, meta-analysis means you're pulling a bunch of studies together and looking at them, show no difference in fracture risk. And there's one study that showed actually reduction of fracture risk. So maybe it was protective against fractures to be on a GLP-1 agonist medication. But
Wow.
what might be the mechanism behind that? There's some basic science data to suggest that there's some upregulation or greater production of something called osteocalcin, which contributes to our bone health. If osteocalcin has other effects, it also acts on skeletal muscle, on fat, and on pancreas to help with glucose control. So there's an anti-inflammatory component to these GLP-1 medications, but there's also this, bone promoting component by increasing the amount of osteocalcin that is synthesized. So, and taking into account that possible mechanism plus what we're seeing, like no increased risk of fracture or possibly reduced risk of fracture, there seems to be possibly a bone protective effect of these medications.
Wow.
And then in terms of joints, there seems to be a mechanism, an anti inflammatory mechanism for joints related to receptors in the lining of the joints as well. So, from my take, looking at the current studies that are coming out on this, I'm seeing potential benefits to reducing joint inflammation, also, obviously, improving, glucose control, but maybe some bone protective effects. And just in general, certainly like weight loss is helpful for joints, like weight bearing joints. But also, if you think about when we look at obese people with obesity, they're more likely to have arthritis, not just in their weight bearing joints, but also their non weight bearing joints. They're, shoulders, hips, and knees. So you don't, unless you're walking on your hands, your shoulders aren't really weight bearing. And that's probably part of that inflammatory, like metabolic aspect of obesity. And so if these medications they may be, number one, mechanically unloading weight bearing joints by taking some load off of them, quite literally, that can help joint pain. But this anti inflammatory aspect of these medications, both through glucose control and maybe also direct effects on the joints themselves, is probably making, people's joints feel better.
That's really exciting because we had heard a lot of people were worried that you're losing muscle, that it's gonna maybe cause bone loss, so
Yeah. I mean, there is some loss. Yes, there's some studies show some loss of lean muscle mass, but in many studies it's proportionate to the mass that is lost. And I do think it's super important for people who are using those medications to be like make sure like because people are eating less, make sure the food you're eating is nutrient dense, like get enough protein, fiber, fruits,
Right.
vegetables, thinking about the quality of the nutrition you are getting, and then strength training to try to not, lose that lean muscle mass at the same time, I think is important.
absolutely.
Yeah, but that's a hot topic now.
So, being mindful of our time today, Dr. Wittstein, what are 2 things we can do today to improve our bone and joint health and age strong?
Just 2 things. So for my number 1 recommendation for women would be to embrace strength training. I think there's a really tough mindset to get out of, like, so many people think of exercising as cardiovascular exercise only, and I think just kind of really work on incorporating if you can't get 3 days, get 2, but try to embrace strength training on a regular basis because that is going to help your bones and joints in the long term. And then, the other thing I think huge decision point for women to make is hormone therapy or not. And I think from my perspective, I just see that there are so many long-term musculoskeletal consequences. From my perspective, some of the most long-term quality of life and even, mortality impacts on women are musculoskeletal and just ameliorating that loss of bone density, loss of skeletal muscle mass, and helping with joint inflammation, potentially reducing possibly risk for arthritis. I think those are huge long-term benefits. So I think I just want people to be aware of those potential benefits and factor that into their decision making.
Yeah, I think that's so important. Even for myself, I'm 48, so I'm in that perimenopause window, but I have family history of breast cancer, so it's a
Mhm.
little bit of a tricky thing, but I think I'm gonna push to get that DEXA scan to see where I'm at because
Oh, yeah.
that would
Yeah.
factor maybe in what I would decide to do.
Yeah. So if you'll give me 3 things, I would say get your DEXA scan.
Okay.
If you let me
Cool.
say 3 things. I would say, yeah, think about, as a woman, thinking about getting a DEXA scan at age 50, not 65.
Yeah, I just went for my wellness and I was like very proactive with my doc about that because he was like, "Well, we'll see if they approve it." I was like, "Yeah, let's give it a shot. If not, then I'll just do it myself." Because I'm 58. So it's like, but thank God I've been training for a very long, long time and I train, very heavy and I do all the things. So we'll see what that comes out. But, Kristen read your book and she has said that in your book, you mentioned that a person's likelihood of developing osteoporosis depends on bone mass attained by the age of 30. So I just want to ask this last,
Well, it's one factor.
what was that?
It is a factor, but don't feel defeated if
Right. Is it too late? That's the thing.
it's not too late. And actually, most of the studies that look at the impact of strength training or some of this light impact exercise, that kind of stuff, are on menopausal women with diminished bone density. So you can gain, a few percentage points in your bone mineral density in a 6 to 8 month program with strength training, for
Yes.
instance. And a few percentage points of gain in bone density translates to many percentage points in reduction of fracture risk. So even a few percentage points of gain is a big victory because your natural history should be to lose 1% per year. So if you're expecting to lose a little, but you gain a little, like that's actually a big improvement. And so there are big impacts even for people who start doing these things like at at or after menopause.
So it's never too late. I love that
Yeah,
message.
yeah.
Never too late. And if you're not losing bone density, you are winning because that means you're gaining.
Yeah. And I just want to add to that because I have a client specifically, this amazing woman. She's been training with me. It's been at least 12 years. But when she started, she came to me, but she was around 65 and she got the whole bone thing. And she looked like a very frail looking woman. Her bone density was like really tanking. And she's still training. She just got her wellness and she's like, her bones have gained percentages, but she has built so much muscle.
Mhm.
And so, yeah, she's like 78 now and she's killing it. So, yeah, it's never too late, guys.
So it's never too late.
Yeah, I mean, that will help her in the long run for sure. Yeah.
Yeah.
Absolutely.
Yes. So it's true. You don't really we do peak in our bone density at age 30, but it's never too late to start combating bone loss and making changes. And so like I said, a few percentage points improvement is a big deal. It might not flip you out of osteoporosis or might not flip you, out of osteopenia necessarily,
Right.
but gaining some bone density has, major impacts on reducing your risk of fracture.
I want everyone to know you can connect with Dr. Wittstein on Instagram. Her handle is at Jocelyn_Wittstein_MD. And definitely check out her new book, The Complete Bone and Joint Health Plan. And I have to say, I have it. If for people that are watching the video, you can see here's the copy. It's laid out beautifully. It's very easy to follow, and it has exercise, nutrition, and supplement recommendations and some recipes, which I'm excited to try too. So it's very cool. It's very easy to follow. I love it. Thanks so much. Thank you for coming on.
I hope you enjoy it.
Yeah. Thank you so much. Thank you for
Yeah,
coming
thanks for
on and
having
writing that book.
me. You're welcome.
We need your support. If you're enjoying the show, follow, like, and subscribe. Thank you for Aging Strong with Functional Moms Podcast. The information provided in this podcast is for informational purposes only and is not intended for the purpose of diagnosing, curing, treating, or preventing any disease. We are functional medicine certified health coaches and not licensed medical professionals. The opinions and advice of guests are their own and also not considered to be medical advice. Always consult with a healthcare professional when making any healthy lifestyle changes. We would love to hear from you. Please leave a comment or review. Email us at info@functionalmoms.com. If you enjoyed this episode, please hit the subscribe button.